Esophageal carcinoma can be squamous cell carcinoma or adenocarcinoma. In India, around 90% of esophageal carcinoma is squamous cell carcinoma, whereas in Western countries, 70% of adenocarcinoma esophagus is adenocarcinoma. The carcinoma esophagus is a bad disease because the 5-year survival rate is only 10%, and also the patients usually present late with the carcinoma esophagus. Since the patient usually present at advanced disease, so we can only offer palliative therapy for them. So the 5-year survival rate is very bad, that it's only 10%. In India, carcinoma of esophagus is more common in Karnataka as well as in Odisha. The most common symptom with which the patient present is dysphagia, which is difficulty in swallowing the food and liquids. If the patient present with dysphagia, then it suggests it's an advanced carcinoma and it's usually inoperable. So it's a bad disease. To physiology of this condition, under etiology, the males are most commonly affected compared to females. Usually the age of presentation is more than 45 years. If the patient has obesity, they have increased risk to develop esophageal carcinoma. The postulated theory behind this is the GERD, gastroesophageal reflux disease secondary to obesity, will cause the occurrence of Barrett's esophagus, and which may later turn on to esophageal carcinoma. And one of the genetic condition called as stylosis, which is also called as Holz-Biewan syndrome, where there's hyperkeratosis in palms and soles, is associated with esophageal carcinoma. Some carcinogens like smoking and excessive alcohol intake and mycotoxin, characteristically in China, in Henan province, the Geotrichum candidum, where this fungi is found in corn and pickle. The consumption of this fungi, the mycotoxin of this fungi, is being postulated to be the risk factor for esophageal carcinoma. We have HPV infection 16 and 18 strain causing esophageal carcinoma, the same strain which causes the cervical carcinoma. We know in carcinoma cervix, it activates E7, E6 and E7 proteins, which causes decreased activity of tumor suppressor genes like P53 and retinoblastoma gene. So this is by similar mechanism causes esophageal carcinoma. And also the H. pylori infection, the infection of the patient with H. pylori has been found to reduce the risk of adenocarcinoma So H. pylori is somewhat protective against carcinoma cervix. Carcinoma esophagus. Then we have, this is about the carcinogens and infections causing carcinoma esophagus. Then we have the increased risk of the disease, the carcinoma esophagus, in some conditions. The increased risk of carcinoma in upper 1/3 of esophagus is seen in case of Plummer-Vinson syndrome, where 15% of these patients with Plummer-Vinson syndrome who presents with the triad of esophageal web, anemia and dysphagia develops esophageal carcinoma. The intake of corrosive like sodium hydroxide, potassium hydroxide, characteristically seen lye, which is used for drain opener. So intake of this alkali will cause the corrosive injury to the esophagus in the middle of the third. The intent can be accidental or it can be suicidal. It causes stricture in the middle 1/3 of esophagus. So 30% of these patients with lye stricture will develop esophageal carcinoma in future. Then the carcinoma in lower 1/3 of esophagus can be associated with the achalasia cardia. In 30% of patients of achalasia cardia develops esophageal carcinoma. And GERD, gastroesophageal reflux disease with the Barrett's esophagus, has been found to be the pre-malignant conditions leading on to esophagus, carcinoma of esophagus. These are the etiological factors leading on to carcinoma esophagus. We see 17% of tumors in upper 1/3 part of esophagus, 50% of tumors, which is the most common site, in middle 1/3 part of esophagus, and 33% of tumor in lower 1/3 part of esophagus. Characteristically, we see the lower 3 centimeter of esophagus is being lined by the columnar epithelium. So we see commonly adenocarcinoma in this region. Coming to spread of the tumor, we have direct spread. The direct spread is more common in case of carcinoma esophagus because the esophagus doesn't have the serosal covering, which causes easy spread of this malignant cells to spread happily. So coming to direct spread, in case of upper one-third of tumor, the tumor can invade through the muscularis propria of the esophagus, and then it can spread to surrounding trachea, left bronchus. Here you can see it can spread to trachea, left bronchus, can spread to aorta, and get adherent to these structures. We know the left recurrent laryngeal nerve will loop around the aorta, so it can involve the left recurrent laryngeal nerve also. It can become adherent to these structures, that is trachea, left bronchus, aorta, and recurrent laryngeal nerve. In advanced disease, this adherent tumor can go on to form bronchoesophageal fistula, tracheoesophageal fistula, and esophago-aortic fistula, and then patients with recurrent laryngeal nerve, left recurrent laryngeal nerve involvement will have hoarseness of voice. In case of bronchoesophageal fistula and tracheoesophageal fistula, the patient will have recurrent lung infection, that is recurrent pneumonia attacks. If the patient has esophago-aortic fistula, it can lead on to torrential bleeding and patient can bleed to death. So in case of bronchoesophageal and tracheoesophageal fistula, we can do endoscopic stenting, which we'll discuss later. This is about the direct spread of the disease. We have lymphatic spread. The submucosal lymphatics of the esophagus will cause spread of the tumor cells by two mechanisms, that is lymphatic permeation and embolization. Lymphatic permeation is spread of the tumor by longitudinal tract, meaning it propagates longitudinally upwards in the lymphatics. Spread by embolization means the cluster of cells will spread from the lymphatics to the lymph nodes and all. So by this spread from the primary tumor, there can be so many satellite nodules seen in the esophagus. These satellite nodules are seen, so we'll see while during surgery. The margin taken in case of proximal part is 10 centimeter because of this reason of the satellite nodules. From upper one-third part, the tumor can spread to neck nodes, that is supraclavicular lymph nodes, causing it enlargement. The middle one-third part, it can spread to thoracic lymph nodes like paraesophageal lymph nodes, tracheobronchial lymph nodes, and subdiaphragmatic lymph nodes. From lower part, the lymphatic spread can be to the celiac group of lymph nodes. This is about the lymphatic spread. And also the carcinoma esophagus can spread by hematogenous route to liver, causing ascites, and lungs, causing secondaries in the lungs, and then it can spread to bones and brain. This is about the location and spread of the tumor. Then let's see the clinical manifestation of esophageal carcinoma. Due to the lesion, that is the tumor, the patient will have complaints of recent development of dysphagia, difficulty in swallowing food. Difficulty in swallowing food occurs when more than 2/3 of the lumen is occluded by the tumor, and the dysphagia is progressive type. So you can see, since more than 2/3 of the lumen is occluded by the time that dysphagia develops, the patient will have advanced disease, and we can't give full curative therapy for this patient. So this disease has bad prognosis. Then the patient can have the less common symptoms like regurgitation of food due to tumor and hematemesis. As with all tumors, these patients will have loss of appetite, weight loss, and cachexia. Due to spread, that is spread to surrounding structures, due to invasion of nerve, the perineurium invasion will cause the abdominal and substernal pain, hoarseness of voice due to involvement of left recurrent laryngeal nerve. Due to involvement of phrenic nerve, the patient can have hiccup. Then the patient, due to the development of bronchoesophageal or tracheoesophageal fistula, can have recurrent bronchopneumonia. And the lymph node involvement, we have the left supraclavicular lymph node involvement called as Troisier sign, where the supraclavicular lymph nodes will be enlarged. Due to involvement of celiac group of lymph nodes, the patient will have back pain. And we know by hematogenous spread, it can spread to liver, causing ascites. This is all the clinical manifestation that we see in esophageal carcinoma. Next, coming on to the investigation done in esophageal carcinoma, we have blood investigations, in which if you do CBC, the complete blood count, the hemoglobin level can be decreased. It can be due to melena or hematemesis. The LFT can be impaired. Liver function test can be impaired due to the secondary spread to the liver. On doing we do USG abdomen, the ultrasound of abdomen, to rule out liver secondaries and to look for enlargement of cilia group of lymph nodes. On barium study, barium swallow, characteristically the esophageal carcinoma will show shouldering sign. The shouldering sign means there is abrupt continuation of normal esophagus to this the obliterated esophagus, the strictured obliterated esophagus. It is called as shouldering sign. The strictured obliterated esophagus had been called as rat tail or apple core appearance. Then we do chest X-ray to rule out any chest lung secondary. Then by barium swallow we can also notice the fistulas. We do some endoscopic procedures like esophagoscopy, where we can visualize the tumor and we can take biopsy from the lesion and do histopathological studies where we can see the features of squamous cell carcinoma or adenocarcinoma. We can do endoscopic ultrasound in order to find the depth of invasion of the tumor. The depth of invasion is important because the tumor staging is based on depth of invasion of esophageal wall. And also we can see the mediastinal lymph node involvement in endoscopic ultrasound. Then we have other investigations like if the patient has involvement of upper 1/3 tumor of esophagus. If the patient has tumor in the upper 1/3 part of esophagus, we can do bronchoscopy to look out for if the patient having bronchoesophageal fistula. We can do laryngoscopy to see whether there is recurrent left recurrent laryngeal nerve involvement and vocal cord palsy. Also, we can do thoracoscopy and laparoscopy to look out for direct spread from the esophagus to the surrounding tissue. We saw it can spread to bronchi, it can spread to aorta, it can spread to the surrounding pleura and other structures. So we can do thoracoscopy and laparoscopy to look out for direct spread from the esophagus lesion and also to look out for lymph node spread. We do PET-CT, that is positron emission tomography scan, to look out for metastasis and response to therapy. The local extension of tumor can also be noticed by CT scan with 95% accuracy. This is all about the investigations done in the carcinoma of esophagus. Next, coming on to treatment, we divide into two parts, that is curable carcinoma esophagus and the incurable type, where we only give palliative therapy. The palliative therapy is given in around 80% of patients because we already saw the esophageal carcinoma usually presents late in the advanced disease, where we can't give definitive treatment for the patient. In the lucky patients where the disease can be cured in 20% of patients, if the patient has T1A disease, we'll do endoscopic submucosal resection. Before that, let's see the staging of this tumor, that is esophageal carcinoma. Under staging, we have TNM staging, the tumor staging. The T1 disease is the invasion into lamina propria, muscularis mucosae, and submucosa. The involvement of lamina propria and muscularis mucosae has been considered as 1A. The invasion of tumor to the submucosa has been considered as 1B. The involvement of muscularis propria or muscularis externa of the esophagus is being called as T2 disease. This involvement of muscularis propria. If there is invasion of the surrounding connective tissue of the esophagus, it is called as T3 disease, that is invasion of adventitia. If the patient has spread to the adjacent structure, which is resectable, the resectable adjacent structures like pericardium, pleura, and diaphragm, it is called as T4A disease. If it is unresectable adjacent structures involvement, that is involvement of aorta, vertebral body, or trachea, it is called as T4B disease. Then we have nodal spread staging. The N0 is no nodal spread. N1 is 1 to 2 regional lymph nodes are positive. In N2 disease, 3 to 6 lymph nodes are positive. In N3 disease, more than or equal to 7 lymph nodes are positive. M0 disease is no metastasis. M1 is presence of distant metastasis. This about the staging. In T1A disease, we do endoscopic submucosal resection. Endoscopic submucosal resection is where a two-channeled endoscope is passed. We are doing in T1A disease, where only lamina propria and muscularis mucosae is involved. We'll pass a two-channeled endoscope Then we'll pass a cap-like thing where we create a suction in order to grab hold of this lesion, and then we'll pass a snare and cut this lesion, the tumor. This is called as endoscopic submucosal resection. Then we have T1B N0 or T2N0 disease. In T1B N0, we know that the submucosa is involved. In T2, we know muscularis propria is involved. In this stage, with no nodal positivity, that is N0, we perform esophagectomy, that is removal of esophagus, where the proximal margin taken is 10 centimeter, the distal margin is 5 centimeter. The reason of which the margin is so much because we can have satellite lesions in case of the esophageal carcinoma due to spread of tumor from submucosal lymphatics. So under esophagectomy, based on the site, we perform different kinds of esophagectomy. If it is post-cricoid tumor, it's usually squamous cell carcinoma. Mainly, we give radical radiotherapy with 5,000 to 6,000 rats radiation. And in some patients, we can perform pharyngolaryngectomy. This is in post-cricoid tumors. Coming to tumors in upper one-third part of esophagus, we usually give radiotherapy, or else if the tumor is early and operable, we can give Mecnion 3-phased esophagectomy. In this surgery, what is done is, first we perform laparotomy. On performing laparotomy, the esophagus and the stomach is mobilized. Then we perform thoracotomy. By performing thoracotomy at the 5th intercostal space, we mobilize esophagus in this part. Following this, we give right neck incision, and by right neck approach, we'll perform esophagectomy. The mobilized part along with the growth is removed by right neck approach. And then following that, the stomach, the tube of the stomach is taken and it is anastomosed with the pharynx. This is called as Mecnion's 3-phase esophagectomy. It is done in upper one, if the tumor involves upper one-third part of esophagus. If it involves middle one-third part of esophagus, we perform Ivor Lewis operation, where the last step is omitted, that is neck approach is omitted. We perform 2 steps, that is laparotomy where stomach is mobilized, thoracotomy where esophagus and the throat is mobilized, and we perform partial esophagectomy followed by gastric anastomosis. You can see here the esophagus and growth has been removed by laparotomy and thoracotomy, followed by anastomosis of the stomach with esophagus, that is esophagogastric anastomosis. This is Ivor Lewis operation. And then we have, this is for middle one-third tumor. The tumors in lower one-third part of esophagus, which can be squamous cell carcinoma or adenocarcinoma, we perform left thoraco-abdominal approach. By left thoraco-abdominal approach, we perform partial esophagogastrectomy. The esophagus, growth, and the part of stomach is removed, followed by anastomosis, that is esophagogastrostomy, or we can do jejunal Roux-en-Y loop anastomosis. It is called a sweet approach. This is about the esophagectomy, which is done in these 3 parts: upper one-third, middle one-third, and lower one-third part. Some of the complications of these surgeries are pneumonia, anastomosis leak. Usually the neck anastomosis leak is most commonly seen than thoracic. And then there can be injury to recurrent laryngeal nerve. There can be chylothorax due to injury to thoracic duct. This is about the T1B N0 and T2N0 disease. Then we have T2N1, the T2 disease where nodes are involved. T2 disease is involvement of muscularis propria, or T3 or T4 disease with no metastasis. It is considered as advanced stage. We perform esophagectomy in these patients after neoadjuvant therapy. It is chemotherapy and radiotherapy. Chemotherapy can be given by agents like gemcitabine, cisplatin, 5-fluorouracil, which acts as radiosensitizer. Following that, radiotherapy is given, and following neoadjuvant therapy, the esophagectomy is performed. These 3 things based on the site of lesion. Now, this is about the curable 20% of the patient. In remaining 80% of the patient, where the patient will have advanced disease where surgeries can be done, the surgeries can't be done, we give palliative therapy. The palliative therapy is given if the patient is not fit for major surgery. not fit for major surgery, and if the patient has metastasis to adjacent organ spread or liver spread or spread to peritoneum. Here, we can perform some endoscopic palliative surgeries like endoscopic laser surgery, where the tumor, a channel is created in the tumor using Nd:YAG laser or diode laser, so that the dysphagia symptoms of the patient improves. This is endoscopic laser, or alternatively, we can do endoscopic bipolar dithermy for this reason to improve dysphagia in these patients. Then we can give radiotherapy, that is palliative external radiotherapy or intraluminal radiotherapy. We can give chemotherapy in this patient by using methotrexate, cisplatin, and 5-fluorouracil. If the patient has tracheoesophageal fistula, we give self-expanding metallic stent which seals the fistula. Then we can perform some palliative surgery in this patient like transhiatal Oringer's blind esophagectomy or Kirchner's palliative gastric bypass. The transhiatal Oringer blind esophagectomy is a procedure where the laparotomy is performed. It is a common step in all the operations. So the stomach along with the lower esophagus is mobilized. Following that, here we don't give thoracotomy incision. We directly give left-sided neck incision, where esophagus is mobilized by finger. Then we perform blind dissection from above and below. Using these two fingers, we perform blind dissection from above and below till these fingers meet at thorax. Following that, the esophagus is pulled out from the neck incision, and then the anastomosis is done. This is transhiatal Oringer's blind esophagectomy. This is about the treatment in case of carcinoma esophagus. To summarize, squamous cell carcinoma is more commonly seen in India, that is 90%. In Western countries, we usually see adenocarcinoma. In India, more commonly seen in Karnataka and Odisha. The patients more commonly present with dysphagia, which is usually seen in advanced carcinoma dysphagia symptom. The etiopathophysiology of this condition: if the patients are usually males and more than 45 years of age, they can have obesity, tylosis, carcinogens like smoking, excessive alcohol intake, deficiency of vitamin A, vitamin C, riboflavin, mycotoxin like geotrichum candidum, and HPV 16 and 18 infection has been found to be risk factors for this disease. The pre-malignant conditions or conditions predisposing to this esophageal carcinoma is Plummer-Vinson syndrome, corrosive strictures, achalasia cardia, and GERD with Barrett's esophagus. The pathology: we see 17% of tumor in the upper one-third part, 50% in middle one-third part, and remaining 33% in lower one-third part. The lower 3 centimeter usually we see adenocarcinoma. Spread can be direct spread to the upper one-third. It can spread to trachea, bronchus, aorta, or recurrent nerve. The advanced tumor can form bronchoesophageal fistula, tracheoesophageal fistula, esophago-aortic fistula, which can lead on to recurrent respiratory infections or torrential bleeding. The lymphatic spread by lymphatic permeation and embolization, we see satellite nodules and the enlargement of these lymph nodes like supraclavicular lymph nodes, enlargement paraesophageal, tracheobronchial, subdiaphragmatic, and celiac lymph nodes enlargement. We see hematogenous spread to liver, lungs, bones, and brain. Coming to clinical manifestation of this condition, we have the lesion. The patient will have recently developed dysphagia. Usually, it occurs after the 2/3 of lumen is occluded. It's a progressive type of dysphagia. The patient can have regurgitation of food and appetitosis, loss of appetite, weight loss, and cachexia. Due to involvement of nerve, we can see abdominal substernal pain, hoarseness of voice, hiccup, and then we can see recurrent pulmonary infections due to the fistulas. The lymph node enlargement, the celiac group of lymph nodes can cause back pain, the Trojan sign positivity we can see ascites if the liver is involved. Coming to investigations, we perform blood investigation, CBC, where HB is decreased, LFT is impaired in secondary spread, USG abdomen to rule out spread to liver, and we can see celiac group of lymph nodes enlarged. On barium swallow, we see shouldering sign, lateral tail appearance, or apple core appearance. We do chest X-ray to rule out lung secondaries. Esophagoscopy can be done to look out for lesions and take biopsy from the lesion, the tumor. Endoscopic ultrasound is done to see the depth of involvement, depth of lesion, and mediastinal lymph nodes involvement. Other investigations are bronchoscopy, laryngoscopy, thoracoscopy, laparoscopy, PET scan, and CT scan to look out for local spread and lymphatic spread. Then we have staging of the tumor. T1 disease is invasion to lamina propria, muscularis mucosa, and submucosa. And T2 disease is invasion to muscularis propria, T3 is invasion to adventitia, 4A is resectable adjacent structure, 4B is unresectable adjacent structure. N0 disease, no nodal involvement, N1 is 1 to 2 positive regional lymph nodes, N2 is 3 to 6 positive regional lymph nodes, N3 is more than or equal to 7 positive regional lymph nodes. Under treatment, we have curable and incurable disease. Curable disease, we only see in 20% of patients. In T1A disease, we do endoscopy submucosal resection. In T1B and T2N0 disease, we do esophagectomy. With the esophagectomy done in case of upper one-third part is Mechnion's three-phased esophagectomy. In middle one-third part, we have Ivor-Lewis operation. The upper one-third part and post-cricoid tumor, we usually give the radiotherapy, radical radiotherapy. In the lower one-third part, we perform partial esophagogastrectomy by left thoraco-abdominal approach. Then we have palliative therapy in 80% of patients who have metastasis and not fit for major surgery, where we can do endoscopic procedures like endoscopic laser and endoscopic bipolar diathermy, radiotherapy, palliative external radiotherapy or intraluminal radiotherapy, chemotherapy with methotrexate, cisplatin, and 5-fluorouracil. Palliative surgeries like transhiatal or blind esophagectomy and Kirchner's palliative gastric bypass can be done. If the patient has tracheoesophageal fistula, we give self-expanding metallic stent as palliative therapy. This is all about esophageal carcinoma, the carcinoma esophagus. Thank you for listening.